You may choose to go bald, but when balding isn't voluntary, it can be emotionally troubling. We associate a full head of hair with youth and beauty, so losing your hair can be quite an emotional adjustment. That is why so many men and women spend thousands of dollars on hair restoration. Hair restoration, either through products or medication or surgery, is a multi-billion-dollar industry. But what works and what is BS? Most importantly, what works for you? On our show today is Dr. Craig Ziering, who is the founder and medical director of Ziering Medical Hair Restoration. Dr. Ziering is an industry pioneer, a renowned teacher, and the author of many published articles. Even with so many accolades, he continues to pursue new techniques and technology and breakthroughs, both surgical techniques and hair restoration solutions. Hair restoration is his passion, and he stays on top of this field through ongoing education in the United States and abroad. And I am very happy to have you join us here today.
My pleasure.
Yeah, I just want to kind of get to know you a little bit more and get our audience to know you a little bit more. How did you end up focusing so much of your career into hair restoration? What led you to it, and how did you not only develop your expertise, but the business model that you have?
Well, it's a good question. I started out as a dermatologist. So dermatology, which is the study of skin, hair, and nails. And naturally, in that process, I did a lot of different things. I was drawn towards the aesthetics and the cosmetics of surgery. And in the early 90s, when I started doing dermatology and being involved in hair was in its infancy. During my training program, we did do hair transplants. But the fascinating thing was just the fact that we could move hair from the back of the head onto the top, and then it would grow. And then it became more of an issue as, can we do this naturally and aesthetically? And I felt that hair in particular was extremely intriguing to me because I thought that there was a lot of room for improvement in the process. I thought that it was fantastic that we could move the hair and let it grow, but that there was ways that we could make it more and more natural for people. And so as a result, I got involved in dealing with hair transplants early on in my career, like I said, in the 90s. So now it's been 32 plus years. And I got involved in various techniques and technology and always looking to try to improve the outcome and the experience for the patient. And I kind of set my career around doing that. And I felt that if I was going to try to be the very best at something, I really needed to focus my attention. And so I did that. I did that for hair, for men and for women, not only for putting it on the top of the head, but also for eyebrows and facial hair. And I focused at times on the artistry and how you could make it more natural. And by doing that, I like to look at what happened in nature. I studied people's hair loss to see what progression looked like. What was the natural progression? Where did the hair initially start to fall out, and what patterns evolved for both men and women? And I wanted to try to do that in reverse to bring the hair back, and so that would be more natural as well. And in the beginning, people are probably familiar with hair transplants from the fact that it looked like baby doll's hair or plugs. And we don't like to use that plug term, but that's the common statement. And the reason people are familiar with it is because those techniques were obvious. You'd see the spacing. It was almost done in sort of like rows and grids. There were big plugs, but it was hair, and at that time, that was acceptable for a lot of people. But over the course of time, we went from doing these big round plugs where we took 5 and 6 millimeter plugs out of the back of the head with a punch, with a drill. And we actually took those grafts and put them into the top of the head. And like in surgery number 1, you actually did row 1, 2, 3, 4, 5, and then you kind of skipped over and did, graft B, C, D, E, and you skipped them off over and through that kind of grid. And then later on, we got the idea, well, if we made these grafts smaller, perhaps it would look a little better because they're groups of 16 hairs and a space between them. 16 hairs and a space between them. And so we started to cut them in half. And then we went from cutting them in half to cutting them into quarters. And then in I think the late 90s, early 2000s, we started to look under the microscope at these hair follicles and realized that there weren't these artificial groupings that we were doing of mini and micrografts, of making smaller haired units of ones or twos in the front and using bigger grafts in the back, but they actually naturally occurred as groups of 1, 2, 3, and 4. And that was the advent of what we would call the follicular unit graft. And the follicular unit graft, we took the hairs, looked at them under the microscope, and divided them into their naturally appearing grouping. And that really was the beginning of the most natural hair surgeries that we had. So we had natural groupings, and we tried to reproduce what occurred in nature on the top of the head likewise. And so we went from taking those punches out, those big groupings, and then we actually went from taking those big groupings out one at a time to actually cutting a strip of tissue out, putting it under the microscope, and looking at those individual units and dissecting them out as individual units of 1s, 2s, 3s, and 4s, suturing the back of the hair up so that would be closed, the hair would fall back down over it, and then we transplant those grafts into the front and top. And you'd ask, why would you even conceive of doing that? Why would that seem to work? Well, when people have male or female pattern hair loss or androgenetic hair loss, DHT, which is the bad actor, causes hair to fall out. And these are pre-programmed. The hair in the back and sides of the head is not programmed to fall out. So those are not sensitive to that DHT. So we can take those hairs comfortably and remove them from the back of the head and then put them into the front and top. And over time, we got better and better at the design. So we could create a natural looking hairline. We defined the face better in aesthetics. We added things like temporal peaks on the sides to not only address the aesthetic thirds this way, but to look at the head from this perspective. Because as we age, our face goes like this. And if you bring it back in here, you get more of a better balance with the face. So we did a lot of innovation with that. One of the other things that I was fortunate enough to have named after me is the crown, the back of the head, the whorl, or that bald spot, the Ziering whorl, where I was able to figure out the patterns that developed, and we reproduce those patterns going backwards. Because if you start to thin on the top of your head, if you move your hand in a clockwise fashion or a counterclockwise fashion, you'd find that you look like you have more hair one way or the other. And so what I did was devise a way to reproduce that and put it in the way that's going to follow that pattern to give you more hair, because it's all an illusion. We use a small amount of hair to give the creation of a lot more hair.
When you go bald involuntarily, is pretty traumatic because people associate it with either aging or an appearance that they can't control. Tell me, when people come to see you, what's the psychology of having to deal with your patients? I mean, is that difficult to deal with? Because it is something that let's just talk on men for a second. Men's sense of self can be, very fragile, and we tend to pretend it's not, but it really is.
So the psychological aspects of hair loss are extremely, extremely important to understand as a physician, for men and women, and it's a little bit different. It's definitely a feeling of a loss of self from both male and female perspective, but it's looked at a little bit different. For men, often it's a sign of a loss of masculinity, and even ethnically, with certain Hispanic patients, you losing that machismo. I mean, you no longer have that virility from that perspective of, my hair demonstrates part of what makes me attractive to women, and or other men for that matter. And that's been shown. I mean, it's been shown in studies. It's been shown with people who have been searching for jobs, that someone who looks more youthful is got a better chance of getting that job. And interestingly enough, if you take it to the next level, we have a lot of patients who come to us who say, "Hey, I'm getting back into the workforce. I've had my job for X number of years. Now I've been laid off, or I'm changing careers. Again, after COVID, things changed around a lot, so I need to go back into the workforce in a different area, and I'm going to compete with people that appear younger than me." Right? I feel young. I know I have a lot to contribute, but my hair losses made me look older than I feel. And I want to get that youthfulness back. I want to get my confidence back, and I want to portray that to others. And so that's something that has been very common for us, with men from that perspective. On the female side, a lot of times, for women, we associate as a public, or they have been told, it's a sign of failing health, right? It's a sign of an illness. While there's genetic loss that causes hair loss for both men and women, but for women it's what's wrong? You have thyroid disease, anemia, these things like that. Is there cancer that's the cause of your hair loss? Where again, the majority of the time it's genetic hair loss, and that genetic hair loss can for women in particular be a diffuse thinning throughout the top of the head, or actually loss in the corners. And so we see that quite frequently, and women are often told that shouldn't be the case. That if you pick up a lot of female magazines and women's magazines, you look in there and they talk about hairstyles all the time. They're not so quick to talk about hair loss and transplantation, which is a great procedure for women. We do a lot of female patients. We can tremendously help them. They respond a lot to the non-surgical, and they respond extremely well to the surgical aspect. And even there are so many people that have traction alopecia because of the hairstyles that they have, and they've lost the frontal band of their hair, and they do phenomenally well with surgery.
In my aesthetic practice, as I've aged, so have the patient population, and I do a lot of aging face. And I will tell you, the vast majority of women who are perimenopausal or postmenopausal all have some hair loss, particularly around the temporal area. And as you're doing a facelift, you've got to be very conscientious of where your incisions are going to go. So I think it is far more prevalent in females than most people recognize. And so that kind of leads me to my next question to you: is the demographic of who you see. What percentage are male, female, and is there, does it divide along ethnic lines either? Who are more prevalent to have hair loss and the subsequent hair transplantation?
Yeah, I don't think that hair loss has a gender bias. It affects men and women pretty much equally. Certainly, statistics show 85 million or over 55 million men and 35 to 45 million women in the U.S. alone are affected by hair loss. But it's a significant amount, and again, it's who comes in and seeks treatment with regard to that. But we see almost an equal amount of consultations between men and women. I think more men do surgery than women in our practice. Not that we don't have a fair amount of women doing surgery, but I think it's twofold. Men want more immediate gratification. That is my general, assessment over the last 30 some odd years. So they're more likely to move to that quicker fix of getting a hair transplant surgery. Now, hair transplant surgery, it's important to note, hair transplant surgery puts hair where it's not. But if you have some existing hair, you want to preserve that. So you need to do the non-surgical. But men want the surgery first. They want to move there right away. Women, and again, part of that is because men lose in areas of baldness much more prevalently than women who just diffusely thin. So if you can use for women, if you can thicken their existing hair, that often is satisfactory to many women. right? And 50% of hair loss in women is that diffuse thinning. So if we can thicken that hair up by using non-surgical methods, that's the route that they want to go. However, as you astutely pointed out, 50% of our patients have this M pattern of loss in this frontal temporal region, and they're really good candidates for the surgery. And so those are the patients that do extremely well with surgery, and we often do that. And again, as you say, with ethnicities, we see all ethnicities, and the hair loss, is very common among everyone. I think some distinctions to point out. It's more common because of to have traction alopecia in patients of African American or Afrocentric descent, because you're going to have the braiding or wearing, sometimes the dreads or using extensions in the hair that pull and cause damage to the frontal band. And those patients respond extremely well to surgical intervention. But we also have different types of hairlines that we need to recreate based on ethnicity and gender, right? Men have more recession with the temporal peaks being brought out. Women are going to have a more rounded hairline, in this band here. African American patients are going to want a straighter hairline. Caucasians are going to have more recession. So we're trying to balance that off to create a natural appearance. Also, the type of hair that you work with is different, right? Some people have a harder C curve in the hair itself, and others have straighter, finer hair. And that's where the artistry and the skill of the surgeon and his surgical staff or her surgical staff are so critical to getting a natural result. It's understanding these the ethnic variations, as well as how to handle the different types of hair and to aesthetically create something that's going to look natural.
So you've mentioned some of the reasons for hair loss is traction. Also, you briefly mentioned before DHT, which I want to go into a little bit more. Is hair loss more genetic, more hormonal related, more trauma related, or a combination of all of them?
So the most common cause for hair loss in both men and women is definitely genetic. Okay, it's clearly genetic; it's inherited. However, hormones definitely play a role in that. As you said, as women in particular reach menopause, they see more significant loss. When women are pregnant and then after pregnancy, they can have more loss as well. Sometimes these things overlap, and hormonal changes can unmask a underlying genetic pattern of loss. Illnesses can cause some hair loss. Some of that is what we call a telogen effluvium, or a temporary shedding that can come with illnesses, high fevers. We saw a lot of that with COVID. A lot of stress. Some of that comes back, but sometimes if patients, again, have a genetic predisposition, it occurs much earlier than it would have occurred because it gets augmented because of that trauma or stress and temporary loss. And so, there's things that are actual entities like, thyroid disease and anemia that cause hair loss. There's scarring, what we call scarring alopecias, that are inflammatory in nature. And that causes a whole nother issue of hair loss. And again, that's why you have to have the proper diagnosis, because treatments may be different. And a lot of times when people say they have alopecia, or they use the word alopecia, they're specifically referring to something that only affects 2.2% of the population. And that's alopecia areata. And that's where almost overnight you lose a spot of hair. And that spot of hair can be on the whole head, where it can be totalis, or it can be universalis, where it affects the eyebrows, anywhere you have facial hair, anywhere in the body. So these are it's an autoimmune condition that causes the hair loss.
So I think that's a good point. Because obviously, in the media in the last year, there's been a lot of discussion on the term alopecia, and there's a distinction between alopecia, as you're describing it, and hair loss that would happen naturally too.
Yeah. So by definition, alopecia is hair loss. right? And it's what you put with it. Androgenetic alopecia is a genetic hereditary type of hair loss. Alopecia areata is an autoimmune type of hair loss, right? So it depends on what you're causing. Scarring alopecia is hair loss resulting from an inflammatory disease or a scarring disease.
So we talked about some of the things that cause hair loss. What are the myths out there that don't really cause hair loss? I mean, for example, do wearing hats all the time result in hair loss?
That's probably the biggest one, and I get moms who take their young kids in to me all the time and say, "Can you tell my son to stop wearing his hat all the time because it's causing his hair to fall out?" And it really doesn't. I mean, that's not what's causing the hair to fall out. Friction, right? Traction, those things can. So, I mean, if you're doing something repeatedly with a very tight helmet or something like that, you may be causing some damage to the hair. But hats per se is not.
So, but hair is not a static object. And briefly, you mentioned telogen a few moments ago. Can you describe to the audience what the phases of hair growth and hair falling out actually are for everybody in general?
Yeah, so there's basically three phases in hair loss: anagen, catagen, and telogen. And the two that are most significant are anagen and telogen. And anagen is the growth phase, and telogen is the shedding or resting phase, where the hairs are falling out. And all the hair cycles. So you're going to get the majority of hair is in the growth cycle at any one given time. But there is a percentage of hairs that are in the resting phase or shedding phase at all times. And that's why it's normal. And again, this is something to repeat. It's normal to lose about 100 or so, 150 hairs a day in a shedding situation. That's normal. But if it exceeds that, that's when you want to come see, a dermatologist or a hair restoration specialist, and it's more significant. And then what happens, though, just as another kind of side fact, is people who have long hair, whether they be male or female, if they don't wash their hair every day, then the hairs get caught in the existing hair and they don't exactly shed so much, right? So if you don't do that, sometimes what happens is people say, "Oh no, I don't wash my hair twice a week because every time I wash my hair, I get more and more hair shedding and falling out." Well, they're building up to that. Certain ethnicities don't wash their hair as frequently because it dries their hair out. That's a totally different issue. So, you have to be aware of these differences. And also when you're treating people, you have to be aware of what would be, culturally acceptable to do in everyone's different lifestyles. So that's why, it's important that if you have these issues that you seek someone who's a specialist in all type of hair loss and hair restoration.
Do cultural trends or societal trends affect a business? There, years ago when I was, growing up, shaving your head, you just didn't do that. And now men shave their head all the time, and some look really, really good without hair. I mean, I don't think I would be one of them, but but there are people who really look good. But that must have, you have to take that into account when you're in the hair restoration business. And also, similarly, things that people do to their hair, like weaves and other things like that, that can cause damage that may enhance business. What's going to keep people coming to you, and what's going to keep people away from you?
Yeah, I mean, I think that people, I'm a nice guy. People always want to come see me. So, I'm not really too worried about that. But to speak to that, the trends for eyebrows, for example, have gone back and forth. And, if you live long enough, then you catch them on both sides, right? But, early on, people wanted thick eyebrows. Then they were all plucking their eyebrows because they wanted thin eyebrows. Then they wanted thicker ones again, but they've already plucked their eyebrows, so now they have to come in for eyebrow transplants. So that's one on that side. The issue of, we talked about this before, braiding your hair, dreads, extension, those all cause damage to your hair. And if you do that, again, you're going to need surgery. as far as shaving your head, interestingly enough, has done a couple of things. I think that on one side, there's two, we haven't even talked about this, but there's two viable methods for harvesting hair from the back of the head. There's a method, and again, it depends on how historical you want to be. Because when I first told you, there's the strip method where we take a strip of tissue out, cut that out into ellipse, divide those grafts under a microscope, and suture that area together, right? And then there's what we call the FUE or FUEE, follicular unit excision and extraction, where we take a punch and we remove one follicular unit at a time from the back of the head. And typically to do that, you shave the back and sides of the head, you use a punch, and you're taking this one unit at a time. If you remember back to the intro, we talked about using a punch and taking 16 hairs out at a time, a 5 millimeter or 6 millimeter punch. So when some people say, oh, strip is the old method, FUE is the new method, well, actually, FUE, or the fact of using a punch to remove hair, was actually the initial method. And then someone said, hey, instead of leaving all that open donor that looks like bullet holes in the back of the head, we can actually take a smaller piece, a strip of tissue, get it from the sweet spot, the strongest hair, and actually be able to see them all under a microscope, divide them up, and put them back in, and actually suture it up so you don't thin out the back of the head. So that is still an extremely viable technique for people that have extensive hair loss. And to be honest, it's the best technique for women, because for women, you don't want to shave the back and sides of the head. And even if you did it another technique, you don't want to thin out hair that's generally thin. I mean, a lot of women who wear extensions, where are they wearing extensions? In the back of their head, right? So when you tell them, hey, we're going to do a technique that's going to thin your hair out further in the back, they look at you like you got three heads. Why would you possibly entertain that? Whereas opposed to if you take a strip of tissue, you sew that together, there's no thinning out of an area. Contrary to that, on a contrast, and I'm taking the long route to get back to your initial question about shaving heads, you can take them out one at a time, right? And if we take them out one at a time, you're diffusely thinning the area out, but you're doing so without giving a linear scar. And if you're going to wear your hair short, now you don't want a linear scar. If your hair's at a 2 on a clipper or better, you're not going to see a linear scar because your hair is going to cover over it. Most women have longer hairstyles. Again, you're not going to see it. You don't want to thin it out. You're never going to see that scar. But if you choose to shave your head today or at some point in the future, you'd rather not have a linear scar. So by taking them out one unit at a time, we can do that. Now, to your point of shape, so that's why we want to consider that in the future for young individuals who may say, you know what, I'm just going to shave my head and keep it short. However, just like you said, shaving your head, it may look good shaved, but often it looks good shaved with some shadowing, right? So where you have the impression of still some hair follicles in the front throughout the top of the head. So some patients who shave their head now and say, I want to keep my hair short and shaved, actually want us to restore that frontal zone to frame their face. Again, it gives them a more youthful appearance. And often we can do that in combination with what we call scalp micropigmentation, which is another technique that we use to augment the procedures. And that's kind of like, for your viewers, a tattooing technique, but it's not a permanent technique, and it's done by someone who has extreme expertise in hair and hair follicles and growth cycles and patterns and so forth.
Yeah, I've seen some magnificent micropigmentation work in some of my patients on my burn practice who've got significant scar alopecia, and they really can't have anything. But with the very skilled person, I mean, it looks like they've got this little stubble on their head that they're not really bald, that they've chosen to be, have that short hair look, which is pretty remarkable, some of the options that you have.
Yeah, and it looks fantastic. And just think about it, if you don't have any hair and you do that, it looks good in that dimension, right? Add the third dimension of having some hair follicles in between that, and it looks that much more natural, right? You're preventing light from shining through, so you're blocking the light and thinness, by using some of the pigment, and then you have the hair follicles, so it adds that third dimension. And it's a great technique without having to do too much surgery.
So let's talk about the procedure itself, because whether you're doing the follicle unit strip surgery or the follicle unit extraction of the smaller units nowadays, it is a relatively time-consuming procedure and has to be for the technician or the physician a very tedious procedure to do it and to do it well. Tell the audience how it's done.
Yeah, so the procedure does take all day. I mean, it's definitely a time-consuming procedure to do it the right way. Essentially, you've had a consultation and a discussion about what the plan is going to be. And so the initial part of the morning for surgery is we draw out and agree again on the hairline and the zones that we're going to treat and the priority zones and how we're going to do that to create a natural look. So that's the first thing that occurs. And the procedure, and that's done before the patient receives any kind of medicine. We're just doing that first thing. We go through that. Sometimes patients will even have a significant other with them or on the phone. Hey, is this what I want? We show them with a mirror. We take a picture of it so that they can see it. And that's the most important thing from my perspective, is to make sure that the patient understands that I get what they want, and we're going to give them, we're going to meet their expectations with regard to that. So we do that design, then we choose the donor hair, where we're going to take the hair from, depending on that method. It may be the strip method that we take them out, or one at a time. And then we'll use local anesthetic. So we do local anesthesia to that area, similar to what you get when you go to the dentist. We give a little pill to relax them, a little bit of Valium, which is a muscle relaxer, also a little bit of an amnestic, so that if my jokes aren't good that day, they forget all about them. And then we numb the area up. We're nice and relaxed. Sometimes we'll even use Pronox. I'm sure you're familiar with Pronox, where it's kind of like nitrous oxide. And we can get very relaxed, for the procedure. We don't knock them out. It's too long of a procedure for that. And then we do the harvest part of the procedure, and that's the taking of that tissue. And it requires a whole team. If we take the strip out, the doctor will take the strip out. We suture that area up, and then I'll pass that on to my surgical technicians, who will divide those grafts under the microscope into precisely the type of grafts that I want. They'll divide it into the follicular units that we talked about, 1s, 2s, 3s, and 4s, precisely the way I want them. If we're doing FUE, then we're removing them one at a time. So the surgeon or the physician assistant will remove those grafts one at a time, and all of them have to be complete before we can move to the next stage. When we're doing the strip tissue, while the rest of the staff is dissecting the grafts under the microscope, the surgeon can then numb up the front and create the little incisions at the angle, direction, orientation of where all those grafts are going to go. And, an average case is 2,500 plus grafts. So that's 2,500 incisions into the scalp at the angle, direction, orientation, and so forth, giving the proper distribution to create the natural design of where we want to restore the hairs. So then, once all the grafts have been dissected and trimmed, and even if we do one at a time, FUE, we still look at them under the microscope in our clinics, because we want them all to be uniform. We want to make sure they're great, viable grafts that we're going to put back in, because these are mini organ transplants. Each one of these are full thickness grafts where the graft is going to grow. Once you remove the hair from the back of the head, it's not going to grow in that area anymore. It's going to grow in the new area, and it will cycle. Just like we talked about, the 3 cycles. Well, it will continue to cycle when we move the hair. And that's the fascinating thing about the hair follicle. So we would then make the incisions for the top of the head, where we're going to have the thinning hair and loss. And then we put the grafts in one at a time into those incisions in that natural pattern. So that whole process pretty much takes the entire day to do, as you can imagine, because we're doing them one at a time.
So as technology has changed and advanced, What tools do you feel are helpful now, and what do you feel maybe not be helpful? For example, what is your feeling about robotic assistance with follicular extraction technique and implantation?
Yeah, so that's a great question. So I think that initially, and I was one of the early adopters, and actually had a beta site for the robotic system, or the artist system. Initially, it was really good at figuring out and monitoring how you extract the grafts, because we could actually program it to some extent. It could see which were the stronger grafts, which were the weaker grafts, and you actually could learn about the angle and dissection of the grafts because it recorded them. So I actually trained all the fellows initially on that device. Unfortunately, the only one company was involved in the robot, and they abandoned the technology. So they stopped to improve the technology, and instead of continuing down that path of perfecting the harvest, they stopped that and then went into, well, let's see if we can make incisions. And they tried to do parts of all the procedure, but not the whole procedure. So they wound up trying to market it to not hair restoration surgeons, but people that wanted to kind of pick this up in their practice, but aren't capable of doing the whole procedure. And yet they thought that this would, replace a doctor, and it absolutely does not replace the doctor. And again, unfortunately, that company stopped advancing the technology. So in hair restoration surgeons' hands, the tool became archaic.
So,
And so
along
that's really essentially what happened.
those lines, if you, and I have to imagine it's very similar in your field. We'll see people who say, I never get plastic surgery. I can see it across the street, and it's just bad. It looks bad. And of course, that's because, that happens to be not a good example of plastic surgery. Yeah. And the vast majority are ones that you don't know. You must see that with hair restoration as well. You mean, some people say, I can tell somebody with hair transplants from, a mile away. And yet that's not necessarily exemplary of good hair restoration surgery. So what differentiates a good hair restoration surgeon versus someone who's not so good?
Yeah, so that's a loaded question, right? But I mean, you're absolutely right. Is that, and I say this all the time, my best work goes unnoticed, right? So it's very different than, for example, breast surgery, where people want to notice it. For example, for me, I want people to have a conversation, with a patient of mine, and be totally focusing on their face and what they're saying, instead of their eyes drifting up and going, "What? Something looks a little off," or "What's that?" or "What? Their forehead's too long. Why is that off?" So, interestingly, I'll have other companies that have actually used my patients, and they don't even know they're my patients, that have been celebrities, that they say, "Would you like to have your hair look like this person?" Right? Saying that they're not hair transplant people, not that they knew of, and they're actually patients of mine. So that's a good compliment for me from my colleagues who don't even know. But for patients in general, how you get those results is you have to have a surgeon that combines artistic ability with good surgical skill. And as great as I think I may be in my own mind, I understand I'm only as good as the weakest link in my whole program here. And it's a team effort. So I think I have some of the best surgical assistants in the world. And I think that's what makes us really good. I truly like to say to my patients and try to profess that I want to be the weakest link, because I'm pretty damn good at what I do. And if I'm the weakest link, my patient's going to get a very nice result. And so I think you need to have really good skill and repetition and experience in doing these types of procedures, so that there's really no surprises. You know what you're doing with different hair types, with different ethnicities, with different genders. It doesn't matter. You're never going to get confused about what you should do. And again, 30% of what I do is fixing other people's work. And I don't want to say that that's because it was always bad. It's just they may not have had the experience or know what to do, or they did it years past where the technology and the artistry and the techniques were not as good.
In all forms of medicine, when you're doing transplantation, organ transplantation, tissue transplantation, there is a risk of loss, and there is loss. What's the percentage of hair loss after hair transplantation, or lack of success in general? I'm sure everybody has different numbers, but across the board, what's the risk of hair loss?
So,
Non-success.
so I know in facial plastics, right, when you're cutting into the hair, there's often some hair loss that occurs with that. Are you specifically asking about what the old term used to be shock loss, or are you talking about what hair doesn't grow that's transplanted?
Both. What I wanted is that the consumer to understand that not everything is going to take, and yet some things are taking but may not be apparent right away.
Yeah. So first of all, and again, in good hands, right? Because what's really important to understand when you look at a hair follicle, and let me see if I have a prop. I'm going to get a prop. Hold on.
I like props.
Pause. Let me prop. So Coke's paying me $100,000 to show
How come we
this
don't get
in the video. So I want to make sure you guys show it. Okay. I get $100,000 each time it shows up, and I'll slide you guys a couple bucks. Don't worry about it. Yeah, I just want them to send me a can or a case or something. Okay. So when people have hair transplants, it's really important to understand with regard to when we say that, how many hair follicles grow or what grows from the procedure. We'll often say that 93 to 97% of the grafts grow. Okay. And yet there's a certain percentage of hair, less than 10% or around 10%, that's in a resting phase that we're not actually seeing, but moving them, right? We're not counting them. And so if we tell you you're getting 2,000 grafts or about 5,000 hairs, you're actually getting close to that 5,000 hairs in someone's hands that are good. Okay. Now, what's important to understand, this is, a little model of hair follicles. And you see, this is the hair follicle, and it comes out to the top of the surface of the skin. Can you see that?
Maybe move it just a little bit closer to the middle of your chest. There you go. Perfect.
Okay. So you can see the hair follicle,
yep.
Right? So this is the terminal hair follicle, or a good hair follicle. This is the bulb. This is the hair coming out through the shaft, right? Well, if you do this procedure, and again, if you do the FUE and you're doing one at a time, and you're taking it from the top here, right? You're blind as to where that bulb is. You can't tell exactly where that bulb is. So if you use a very small punch, what you're trying to do to create the tiny, tiny little scar or pinpoint dot in the back of the head, if you don't understand the angle, and remember I said some hairs are curved, right? So some have a C shape. And, African American patients, for example, much more difficult to do that FUE procedure for. We're known for it, but we're very skilled at doing that. If you transect or dissect or cut across these hair follicles, the base of the hair follicle, when you put it in, it looks like a hair, right? It looks like it's going to grow. But if you cut that bulb off, it's not going to grow in the future. And unfortunately, there are people that go to a lot of places and they think the hair looks great for about 3 to 6 months, but a year down the line, it doesn't cycle again. And they've had it transected. Really good doctors will talk about their transection rate with the FUE procedure, and it should be very, very low, very low. 1 or 2%, it should be a very small number. When you do the strip method, you're virtually getting no transection because you're taking that strip out and you're looking under the microscope and you see exactly how that follicle is laying, and you can cut it under the microscope. So that's why the rate can be so much better. The difficulty is there's not a lot of staff anymore that understand how to do this technique, the strip, what we call slivering of the grafts anymore. So that's something else to keep in mind, and that's why some people have poor growth rates. There's a whole mess of other things that contribute to that. If you're not angling the grafts appropriately, or you put them, and I don't like to say dense pack because you put them too close, but you compromise blood supply, various things like that. If you're not really skilled in understanding what you're doing, you can get tissue necrosis, you can get all kinds of things where the tissue dies and the hairs don't grow. But I don't want to scare people, because hair transplantation in skilled hands, and I'm not the only surgeon that can do this well, then people that have good experience with good staff can get really good hair transplants. But it's really important for people to understand this, okay? And I want to stay away from the turkey topic, except, I've had people ask and write in and say, can you explain that a little bit? But there are people that take hair from the back of the head. And when they take that donor, as we talked about this area, there's only a certain area that's the safe donor zone. If you go too low or too high, that hair is eventually going to be lost. And what's happening sometimes when people are going and saying everyone's a candidate for 4,000 or 5,000 hairs or grafts at a time, they're going outside that safe zone. And so whether it be a year from now or 3 to 5 years from now, a lot of the hair that's been transplanted is going to fall out because it was in an area that was genetically programmed not to be lost. Or they're harvesting them so close that they're really destroying the back of this area, and patients are going and are unaware of the fact that we talked about earlier, that hair doesn't grow back. Once you take that bulb out of there, it's either growing here or never coming back. And so it's really important that some people are not getting what they are expecting to get. And you have to make sure you go to places that are reputable, that understand, that have the experience, and have long-term track records that, for 5 to 10 years or more.
So you need to find somebody who has a level of expertise, and it's going to take a long period of time, and it's going to take, a skill set. That is something that you just are going to recognize is going to be a procedure that's going to cost a lot of money, as does most cosmetic procedures. So there are going to be patients who can't afford hair transplantation, and there are going to be other physiologic reasons why people can't do this surgery. Let's talk a little bit about alternatives to surgery. Now, obviously, there's toupees and weaves and micropigmentation, which you've talked about. When do you recommend that as opposed to surgical intervention?
Well, I think that it's important for people to know that the earlier you intervene with the issue, the better off you're going to be. So I think the more aware that patients are of their situation and their family history, the better off they're going to be. So if young patients who may have hair loss in their family or think they're starting to get hair loss, start with simple topical applications of medicines that we can use that have virtually no side effects, or growth factors that we can use with very little, issues. The cost is minimal. They can hold on to and preserve much of what they've got. So they really don't have to go that far down the path. And I think that's probably the most important thing. Go somewhere to get evaluated, start that partnership early on in your hair loss, journey, so that you can partner with a physician, a doctor's office that will walk you down that path and give you the alternatives that you can use, such as topical medications, oral medications, light therapy, lasers, laser caps that can be done at home. There's growth factors. There's exosome therapy that we do now. People understand and hear PRP all the time. I'm not a big fan because PRP has inflammatory components to it. There are some types that are okay, but there are alternatives. Even if you just go and say, hey, what about PRP or something like it? As we advance the field, there's more and more things that can be done. We have lasers that create little tiny tunnels under the surface of the skin, and we apply the growth factors topically. Those are very beneficial. So there's a lot we can do. The aesthetics that we can use with scalp micropigmentation, and even something as simple as a protein fiber that binds to the existing hair that you can apply. can be done naturally, have virtually no cost, no downtime, no no surgery involved, all that kind of stuff, and it can aesthetically look good. Plus, going back to the very first question that you talked about, take care of someone's self-esteem or that that sense of loss by doing something as simple as that.
Well, you kind of led me right into what I like to do in our sessions called our Beauty and the BS round. And I
Yeah.
want you to tell me quite candidly what you think is good, what works, and what's bullshit, or somewhere in between. All right. The home infrared caps, beauty or BS?
Beauty.
All right. So you think that those have some benefit?
Absolutely. For the right candidate, right? If you're bald, if you're completely bald, yeah.
Good.
Or SB, I got to
I like
probably
the
change
card.
it.
I like the card. Okay. Hormone therapy for hair replacement.
I mean, that's a mixed bag, to be honest, because hormone therapy, I mean, if you're a woman, for sure, it can be a benefit, right? For men, it can work in both directions. So I recommend hormone therapy for people that are depleted and deficient for reasons other than just hair. And sometimes we see it's beneficial for hair, but other times we see it's detrimental for hair.
Minoxidil,
It's good.
Propecia.
Good.
Any other recommendations other than minoxidil or Propecia that maybe?
So I think that both minoxidil and finasteride, in both of them, can be used topically and orally, depending on male, female, etc. A lot of the things that we recommend, and when I say these things are good to some extent, they don't work 100% of the time, but they at least have scientific studies that show that they are beneficial for patients and can improve either slow down hair loss, thicken hair that exists, or actually regrow some new hair, right? So those things can be a benefit. And again, for us, I use a combination layered approach, right? I don't just use one modality. But go ahead.
Platelet-rich plasma, PRP.
I'm more on the BS side of that. The idea was good, but it's really not great. It's not consistent, and it can cause more issues than help.
So briefly on this, let's explain to the audience what exactly PRP is.
Yeah, so platelet-rich plasma is you're taking blood from a patient, you're spinning it down, and you're isolating the platelets, and then you're going to inject them back into the scalp. It's something that can be extremely painful for a patient if you don't numb the scalp because it's thick. But there's so many different ways to spin the hair, to spin the blood down and to isolate that. And it depends on what type of unit you use, what concentrations you get, that there's so much variability. It's very hard to be consistent and to get good, consistent results. And so, it's kind of like that there's so many paints that exist. Some of them are good and some of them don't last and peel off, and some of them can be detrimental. So, I think it's more along those lines. There's not consistent good results with that for hair.
Okay. The last of the Beauty and the BS round, and that is, this is kind of a two-part question, is medical tourism, and in particular, why is Turkey so popular for hair transplantation? Is that beauty or is that BS?
Yeah. So again, I think one of the things that's definitely BS when you talk about Turkey is that I've heard that Turkey is the origin of all hair restoration, which is definitely BS, right? Hair restoration actually started in Japan with eyelash transplants and eyebrow transplants. That's the initial first time, and then for androgenetic hair loss, it was in the U.S. With the punches, and it was discovered by trying to work with someone with vitiligo or the pigmentation disorder. There are a lot of people that go to other countries, medical tourism, for a lot of different cosmetic procedures, and they do so mainly for one reason, right? It's cheaper. The labor is cheaper. A lot of times, the problem with that, if you cut corners, and that's how you get cheaper labor in general or cheaper things, you get less than satisfactory results. And this has happened with liposuction in the past, injectables, right? And then, you hear about that massive rush to a country or to some medical tourism place. And then later on, you see them on 2020 and Dateline with all the horrific stories that come from it. And that's the part that I'm fearful with. I mean, when you say Turkey, there's great surgeons in every single country in this world. Just like I would say there are poor surgeons in the U.S. I believe, again, it is very operator dependent and staff dependent in this procedure. You asked about the use of a robot, and there's other devices that help to harvest this, the procedure. I'm more fearful of, not where you go in what country you go to, but if you say, I'm going to get this done and not understand who's actually operating on you. For example, there are a lot of doctors in this country and abroad that use devices and staff that are not theirs. They purely bring them in, put them in another room, and let technicians, for example, who in a lot of cases are unlicensed or shouldn't be allowed to do that procedure in that various country or in that various state in the United States. And they're doing the entire procedure, something that the doctor doesn't actually have the skill set to perform or to delegate. And I think that's something that we should be fearful of. And I think that that's even worse than some of the things that have happened with liposuction and injectables, in the sense that you get a lot of people not even knowing what they're doing or that are not licensed doing procedures that they shouldn't really be doing. And so that is a big problem.
One thing I can tell you that is not BS and is beauty is a skilled expert in hair restoration, and that is you, my friend. Craig, we are at the end of our time for the podcast right now, and I just want to tell you how much I appreciate you being on the show with me. I know you have clinics in Beverly Hills, in Greenwich, Connecticut, in New York City. Tell our audience how they can learn more about Ziering medical hair restoration clinics.
Yeah, the easiest way is to just go to zieringmedical.com. That's ZIERING medical.com.
All right. Well, thank you once again. I appreciate you enlightening not just the audience, but me. And I was like writing all these things down so I can, be able to be able to give advice to those patients of mine who need it. And it is certainly much more prevalent than just seeing a guy with male pattern baldness. I mean, it's a huge area of help for so many, and you do great work. So thank you for that, and thank you for being on the podcast. And for everybody, thanks for joining us on this episode of Beauty and the BS.
Thank you.
The Beauty and the BS podcast executive producer is me, Dr. Peter Grossman. Our producers are Max Banta and John Largent, and editing and post-production services are provided by Game Day Media. You can listen to Beauty and the BS wherever you listen to your favorite podcasts. And if you'd like to leave a comment or ask me a question, go to beautyandthebspodcast.com and click on the microphone icon, and we may use your comment on a future episode. You can also find our archives, video clips, and more on the website as well. Thanks for listening to Beauty and the BS with Dr. Peter Grossman.